Hello, thank you for your patience. The very first item on my moderator sheet is make sure the session starts on time, and I'm 2 minutes late, so I'm already off script for you guys. I hope you're feeling good on our last day of the conference at least. My name's Corey Herc. I'm going to be your moderator today. I will look at my phone every once in a while to make sure that I've got the names of my presenters right. I'm not texting my friends in the middle of trying to pay attention to you. I just need you to know why we're here. So we are going to be starting off session DH7, What Makes Housing Supportive? Reimagining Care, Connection, and Community. We have 3 presenters today. Each of them will be on for about 20 minutes. We give them a little bit of grace period, but I want to make sure that we have some good time for Q&A at the end as well. So we'll be in here through 3 different presenters. Each of them will be speaking a little bit about their own project, and we'll hold some space for Q&A. There is no live interpretation, mais moi je parle français, donc si vous préférez poser vos questions en français, moi je peux traduire entre vous et les présentateurs. So if you do speak French, I am fluently bilingual and would be honored to translate between you and the presenters if you need, but there's no simultaneous interpretation. Everyone's in the right room? We're all feeling okay?
We're in the right room, but I don't know if that's the right.
It is. It is. It's not the name of the session. It is the name of one of the presenters' presentation. I got you, don't worry. I'm supposed to be here too. All right, super duper. So we would like to begin this session, as in all of our sessions, by acknowledging that our 2025 National Conference on Ending Homelessness is taking place on unceded Indigenous lands. The Kanien'kehá:ka Nation is recognized as the custodians of these lands and the waters in which we gather today, and Tiohtià:ke, Montreal, is historically known as a gathering place for many First Nations as well. Today, home to a diverse population of Indigenous and other peoples, we offer respect to those continued connections with past, to the present, and with the future in our ongoing relationships with Indigenous and other peoples from coast to coast to coast. Personally, I'm joining from the East Coast as well. I live in Signiqtuq and Mi'kmaq, so one of 7 districts of Mi'kmaq territory, near a city now known as Moncton. Signiqtuq is the drainage district, and those 7 districts form the original governance structure of Mi'kmaq and Mi'kmaq territory, each of which governed by a grand chief that formed a council which handled judiciary, social, public, and international affairs for the Mi'kmaq. And so when I offer that too, is I invite you to know not just where are you going and what is the land called, but where are you coming in from? What do you bring into that? My family came here through my father's side as refugees fleeing Soviet annexation of Slovakia, and they came because there was an offer of safety. That safety is something that I bring up because it's unique to our relationship to it, and that I have no doubt that in another world free of colonialism in this area, that the Mi'kmaq could have offered that same safety to my grandfather if he had come seeking it. The treaties of peace and friendship that govern New Brunswick were signed in 1725 and amended through 1752, and explicitly called for shared resources, shared interest, shared future, not cessation of land and cessation of resource title. And so I also offer that as a thought that when we say we're all treaty people, to understand what that means. What are the treaties that govern your land, and what are your responsibilities, particularly in a sector like homelessness, where Indigenous folks are severely overrepresented? And so with that, thank you for being here. Thank you for joining us in the conference. We do not have simultaneous interpretation, like I said today, so there will be subtitles where we can online. Moi, je parle français aussi. Je peux traduire pour vous si vous voulez. And otherwise, it's mostly going to be them talking, not me. Everyone's in the right room. We're all ready to get going. Feeling good? All right, super. So I'd like to introduce our first presenter. It's going to be Hannah Bray, Head of Research from the Old Brewery Mission. Hannah, it's all yours.
Thank you.
Hi, everyone. Is this too close? We good? Good. So as Corey mentioned, my name is Hannah Bray. I'm the head of research at the Old Brewery Mission, which is probably if you've gotten an opportunity to walk around the neighborhood, you've seen the large resource that's just a block over. As a matter of fact, my office is in this building, so you're where the magic happens. I'm also a CMHC SSHRC postdoctoral fellow at the University of Toronto, Mississauga, but don't worry, I don't have to commute. And this work wouldn't have been possible without the support of my research assistant, Alina Kalugin, who unfortunately can't be here today. To give a bit of context to this research, we have an in-house research department. I don't always bring that up when presentations happen, but it's worthwhile mentioning for this project because it was very much a by and for research for the Oldbury mission. We have a research department that my role is to support understanding promising practices within our resources, evaluate our practices, etc. That said, we never really had done any research around our supportive housing program. And since 2016, the Oldbury Mission Supportive Housing Department has embodied the organization's biggest shift in programming. So in 2016, we made this decision that we wanted to go and phase out our shelter model, and we've done that in a lot of ways, but one of them has been massively investing in supportive housing. So currently we have 8 different supportive housing sites, as well as multiple scattered site projects and support staff for Housing First. And cumulatively support over 450 people who have experienced homelessness, but just in that department. We had people come to our transitional housing department, like external researchers with various questions, but we had the misfortune that happens to us very often as a community organization. I imagine this happens to other groups, where the researchers come, they conduct the research, we support them, and then they leave. And they take everything with them. So it behooved us to do something that was by us for us, and we wanted to think about this a little bit differently. We have an extensive understanding of factors around residential stability around when we're thinking about supportive housing in Canada. And usually this is focused on how long can we keep people housed. And fair, if the goal is to keep people within housing, that would be a metric that we would measure sort of the success of our supportive housing. But to us, that wasn't good enough. We wanted to think more concretely about how people were doing when we were thinking about this evaluative practice. And with that, there was an interest in a measure that reflects our organizations around, like our values around well-being. So it wasn't just saying, let's go take an existing metric of well-being, but if this project's going to be really by and for us, let's invest in how we think about well-being and then put that to the pavement and go test it with our participants. So objectives, very simply, were to measure the impact of our supportive housing programming through participants' subjective experiences of well-being, adapt programming to reflect more than residential stability, but really how people were doing. So how did we develop these well-being measures? I started off with a meeting with my supportive housing colleagues. We had a big conversation about what we wanted this to look like. And then I put them up to task, and I said, what questions would you like to know from your participants about well-being? And they developed over 100 questions for what is meant to be a pretty straightforward questionnaire. So I took those back to my office, and then I thematically broke them down into 15 questions, and then said, okay, but you have all these other sort of rich understandings of well-being you'd like to ask from our participants. I'm also going to give them the optional semi-structured interview to kind of fill in the blanks of what that questionnaire doesn't answer. Brought that back to them, we workshopped it all together, and then I hit the road after getting ethics approval from McGill. So methodology, kind of what this ends up looking at, we had a questionnaire. There's 15 questions on well-being. It was a Likert scale, 1 to 10, 1 being lowest sort of perception of that well-being indicator, 10 being it's going fantastic, better than fantastic. And then we repeated this questionnaire as much as possible with our participants in 3-month intervals. Unfortunately, the way we had funding, again, this was a by us for us project. We did not have external funding. It only went up to 6 months, and the 6-month sample is very small. So when we look at the longitudinal value of how people do over time, it's going to be really related to how long somebody's been in their housing when we looked at base, and then that 3-month mark. I'll get that into it in a second. Then we just analyzed it in Excel as descriptive statistics. The semi-structured interview, again, was meant to expand on the questionnaire content. Semi-structured, it was punctual, so it was one time while the other one repeated itself. We had funding to do interviews once with people and capacity to do the analysis. And then there was a $30 gift card honorarium. And then we analyzed all this data in LibQDea, which is, for any nerds in the room, free qualitative software analysis, or free qualitative analysis software. The data was collected between May 2024 and September 25, so up until last month. Recruitment was done directly with posters in our pavilion sites. So while I mentioned that we have scattered site participants, we tried to do recruitment with them, and I can talk about more of that later. It was a total flop. We had 1 participant from our scattered site projects. The majority, so everybody pretty much in the project, came from the OBM owned and operated sites. This is our sample. I'm not going to go through its entirety, but we ended up with 67 participants, 30 women, 37 men, which is an awesome gender split. You can see race and ethnicity as self-declared by participants. Bear in mind, I'm also translating that in a lot of senses, so nomenclature also kind of goes between English and French here. We have people's status is also listed, so majority of the participants were Canadian citizens. We have 4 veterans, 4 Indigenous people, 11 people who indicated that they were employed. I bring this up because this was a surprise to staff. One thing that was important was our retention, obviously, and so we're talking about people who are in supportive housing. There's a lot going on throughout the course of the data collection. We had 5 people who came to the end of their program, so they no longer meet the criteria of the program, or they couldn't adhere to the program itself. 6 people moved into private housing. 13 moved to another program or site, so they stayed in supportive housing, but that particular unit or situation didn't work for them. 1 person was hospitalized, 1 person moved to assisted living, and unfortunately 3 passed away throughout the course of data collection. So in an ideal world, I would have conducted questionnaires with people when they came into supportive housing. But we already had this big, robust supportive housing department with people who had sometimes been there for a long time. So we decided to just open up the questionnaire at base for anybody. And then that gave us people who had been in supportive housing for they had moved in last week, so 0 months, up to 68 months. So we had a huge range of amount of time that people had been in supportive housing. And that gave us another metric of how does people's experience of well-being change over the course of their time in supportive housing. So getting to the questionnaires, I'm afraid it's very small, and I'm so sorry. But you can see the well-being measures as we articulated them with staff indicated on the side. So there was I'm generally satisfied with my housing, I feel stable, I feel safe, I'm generally satisfied with the neighborhood. There shouldn't be anything really surprising here. This was what came up among staff, and then this was kind of how we pared it down thematically. Overall, we can see averages and medians are pretty high across all 15 questions, which is really encouraging. Some of them, it's not as high as I'd love to have it say everyone be I'm having a great time, I'm doing so much better in supportive housing. But generally speaking, we're looking at still above sort of the median point, which I'm proud of. A couple elements of interest. The social life question was one of the lowest scores, generally speaking, across the sample. I'll get into this more with the interview content, but it was something that people spoke about, was that generally this supportive housing context was not propice to people feeling like they had a good social life. And generally they found the space couldn't meet their social needs. Another element of interest, scores are consistently higher amongst women over men, and that's across the whole project. Generally women having a better time in supportive housing, which we can speak to people who are overseeing the different programming, we can speak to the environments. Really, it's hypotheses because this isn't what we necessarily looked at, but it was interesting when it came to the questionnaires to see that women were having a better time. I then take the same questions here and I split it amongst people who were given a room in supportive housing versus people who were given apartments. When it came to the results between living environments, I was expecting much different results for people with a small private room because effectively you have a very small space. But as it turns out, a lot of people were satisfied with the room, and generally when we got to interviews, people indicated, well, it's less to clean, I have just enough space, I feel cozy. So yeah, people were satisfied with the room. Where we do see lower scores in rooms is when it comes to social life. So once again, it's the idea that the space can't quite meet your social needs, and that'll keep coming up amongst the findings. One interesting point is that people who were in rooms as opposed to apartments felt a greater sense of security than people in apartments, and that can be attributable to you have greater proximity with your neighbors, you probably know your neighbors a little bit more intimately, and generally speaking, there seemed to be a stronger sense of community for people who were in rooms versus people who were in apartments. One of the neat things about this study was that we got to do follow-up questionnaires at 3 and 6 months. Whoops. That's not what I wanted. There we go. Folks we interviewed at the first time in supportive housing journey, or folks were interviewed at that 0 to 68 mark. So 68 months being 5.5 years. So we had this big range. And then when we ran the analysis, just where people were at that base, so time spent in supportive housing and the well-being indicators, there was no relationship. for any single one of the well-being indicators. We couldn't establish whether well-being, self-reported well-being, had increased or decreased for any single one of those well-being indicators, suggesting that it's not about how much time you spend in supportive housing. It's about the quality of the space, it's the quality of the accompaniment, it's more of the subjective details than it is the quantifiable time spent that effectively makes your well-being better. And it's a bit of a challenging finding on my part to swallow, but I think it's very telling. Just looking at this. I didn't put it into a graph because I'm just going to spare you the most chaotic graph ever because there was no relationship. So where we see a little bit more of a difference is that when we calculated the differences between 0 to 3 6 months at the questionnaire mark. So when we get down to the individual and we calculate their difference at that 3-month mark to their 0 mark. So for example, after 3 months, say I give something an 8, but at the 0 mark, I gave it a 6, that difference would be 2. We then took that difference amongst the whole sample and then calculated the averages and the median to see if there was anything different there. And this sense of it doesn't make a huge difference, once again echoed by this graph, these were very negligible changes across medians and averages when it came to individual level differences on that 0 to 3 month mark, which understandably, 3 months isn't that much time in the grand scheme of things in supportive housing, so we have to take it with a grain of salt, but I do think this is worthwhile talking about. So getting to the interview results, quality of accompaniment, no surprise this was a big theme when people talked about their well-being in supportive housing. Responses ranged widely when people talked about the relationship with staff, with some people characterizing their relationship with them as life-altering, while others were ready to move out because of them. A lot of people had more passive relationship where counselors were just people doing their job. Generally, participants recognized that how they got along with staff really defined their experience, and it really depended on the staff member themselves. So a lot of people expressed that when there was a high turnover amongst staff and they lost their counselor, it was a huge loss to them and really impacted their well-being. There was also a lot of comments like feeling that staff were not adequately trained to deal with the level of complexity that was often found in supportive housing. Conversely, this also came with a lot of recognition of the strength and resilience of staff. And you can see in that second quote, it's somebody saying like, I can't believe that they don't deal with more. Additionally, participants talked extensively about the lack of clarity around services, and there was this sense that often of like, I feel like they're not telling me everything about the supportive housing, and that's very paternalizing, and we know that a sense of agency is a big factor in well-being, and so people really indicated this loss of, I don't totally know what's going on, and that's not helping me. The physical environment was obviously a huge well-being factor, and this ranged really widely with a lot of details relative to what made a space better or worse. For example, participants often felt that maintenance staff were overworked and too slow to fix chronic problems with our supportive housing. Also important, participants often mentioned being in units that were not physically adapted for them. So for example, somebody with mobility issues being placed on the 3rd floor with stairs. When it came to size, many people appreciated, like I said, having a smaller space meant less maintenance. And for other people, it was awful. It was terrible. Like, how could we do this to them? For some of those participants, they mentioned paying for storage off-site just because the spaces couldn't adequately contain their stuff. To the size point, not being able to have friends and family over was a huge issue across most interviews because that was a rule, and it's also the spaces aren't set up to bring people over. Many people named it having a big impact on their well-being, and it radically impacted their ability to have a dignified social life, to have like a home where you could bring people in. As we see for this participant, the sort of institutional nature of supportive housing, like the details within the physical environment, really impacted his well-being. It reminded him of prison, and it was a reminder that I'm still in an institutional setting and I am lesser. This is not my home. So neighborhood was an important feature. Elements relative to the area were considered important, so like access to essential services and things like parks, like recreation was really important. People really underlined the value of being in a neighborhood that you were familiar with. So people who really liked the neighborhood tended to be people who were familiar with it either at another point in their life or more recently. Conversely, people who had no familiarity with the neighborhood really indicated that that impacted their well-being, no matter how sort of objectively nice the neighborhood was. Some participants also discussed how really struggling being in a neighborhood where there was a lot of visible violence, and this is pretty congruent with what we know about how people do in supportive housing. Community life was something that ranged really widely with people. So community life, I mean talking about living with the other residents in supportive housing. Some of them described a rich community among supportive housing residents that they found as a source of strength and resilience. They made friends, this was good. For others, hell is other people. And they found proximity to their neighbors, especially people with added mental health challenges, to be really damaging to their well-being. And this is something that I've seen in other projects conducted at OBM within other sites, and yeah, proximity to people that you don't know going through really difficult times in their life, not great. Doesn't really help your well-being. So one thing that I think was really interesting was also activities. While certainly some participants indicated having no interest on like on-site occupational activities, having like animators come in, a surprising majority indicated wanting more activities. They just needed things that were better tailored to their level of accessibility. So there were a lot of comments around, you know, I want to go to the museum outing, but I'm really worried that I'll have a panic attack while I'm there. And I just don't want to hold everybody back, and that'd be really embarrassing. So it's the idea of like having low threshold, low barrier activities as well as nice big outings and things like that. But fundamentally, it's important to consult our residents on what they want to do. I could say a lot about the mental health section because obviously well-being, mental health. But this was like pretty widely ranged and it was very subjective to the person. So in talking about it, I'd kind of end up outing a lot of my participants, but many participants indicated having severe mental health challenges before and during their supportive housing experience. So whether or not supportive housing actually helped them or hindered their mental health ranged in the extremes, and I couldn't, based on either the questionnaires or the interviews, I couldn't really say something about the nature of supportive housing on people's well-being. Substance use obviously came up. While many participants indicated no substance use, several suggested that the relationship with drugs and alcohol had contributed to their loss of housing and remained a source of fragility when it came to their housing experience. Some of them had diminished their use, some had increased their use. For those who had increased their use while being in supportive housing, they often mentioned the environment and proximity to other neighbors was something that they made them use more. And this is something, again, that we've seen in other instances. It's not new when it comes to substance use. Beyond talking about how accommodations may or may not have met people's physical health needs, the physical health was named as often, like having access to activities that you could do for improving your physical health often came up. So like being able to take nice long walks in a park. Like we talked about neighborhood, but like long walks were really important for supportive housing folks. People also talked about, in a very positive way, how being in supportive housing had reaffiliated them with a lot of the public health resources that they had been missing before entering supportive housing. And so, like, kudos to our team for really having that tie to public health and really supporting people. And generally, people said, like, I'm on a journey, my health is getting better. How am I doing for time? 2 minutes? Great. Okay. And I think I'll probably go for this as the last interview theme. So one thing that was brought up was transitioning out of supportive housing. Despite the questionnaire answers around remaining in the program, where people indicated, like, I plan to stay in this. Like, plan to stay in this, I think, was more being like, it's okay, I'll see it out. But when we talked to people, and this is, I think, a really important finding, people said, this is not a long stay. I'm not here for a long time. I'm probably not even here for a good time. This is not a kind of environment, this is not the kind of experience that I want to prolong in my life. I am here until I can get to somewhere else. And a lot of people talked about wanting to access social housing out of supportive housing, and this was just a stepping stone. Like, this was just kind of, for some of them, it was like purgatory. Like, I'm just stuck here until I can get to something better. For others, they saw themselves being able to remain there indefinitely, but vast majority of people saw this as a stepping stone. So to wrap it up, self-reported well-being indicators are unlikely to radically change over a few months in supportive housing. And even when we look at a wide range, so 0 to 68 months, we can't actually see any clear relationship between length of time spent in supportive housing and well-being indicators on an aggregate level. Experiences of well-being vary much more according to subjective details, which I think most of us could have probably guessed, but our data certainly spelt that out. Well-being for many people were spaces where they could welcome loved ones. And the way our supportive housing is currently set up and the way I think a lot of supportive housing models are set up, it's not really feasible either by rules or by space. There was a desire for more tailored community activities, occupational supports, so really meeting people where they're at to figure out what those activities that they are to really nourish them. We need to have programming that's focused on dignity and agency that offers a transparency to people about what's going on, what their role is, because otherwise people just feel infantilized and they're losing their agency. And then generally like more of an emphasis on accessibility, whether that be in how we're designing our spaces, how we're accommodating people. A lot of people told me stories of being like, I got no help when I moved in, things like that. Like there's a lot of accessibility concerns that I don't think get expressed on the part of our participants when they move into supportive housing. And I think we need to pay better attention to that. That's it. Thank you very much.
Wonderful. Thank you so much. Are the presentations going to automatically advance to the next one, or do you need me to switch it over back there? Okay. Thank you all for your patience with that. So big thanks once again to Hannah Bray from the Old Mission Brewery. That was wonderful. Our next presenters are going to be coming in from Good Shepherd, both are community mental health workers. It is my pleasure next to introduce Alyssa Felice and Jordan Budick, community mental health workers with Good Shepherd. Thank you so much.
Thank you for that introduction, and thank you all for being here. As he said, I'm Jordan, and I go by she, her pronouns.
And I'm Alyssa. I'm also she, her pronouns.
And we work with Good Shepherd. We've collectively worked there as community mental health workers on the front line for 7 years, collectively. And we just wanted to say, as we start off, that we interchangeably call our clients tenants. So throughout the presentation, we're going to be referring to them as our tenants. It's just kind of out of habit, so we wanted to note that. But today we'll talk about how we foster a culture of learning for tenants and staff, and how that helps us adapt even when change is hard. Okay, so on that note, here's what we are covering today. We will start with unpacking what person-centered care really looks like in our practice. Then we will explore how our staff are supported to learn and evolve. We will then look at our organizational responsibilities to sustain change, and we will close with practical strategies that can help your team and organization adapt to. Oh, no, am I still there? No, okay. Okay. So let's begin with the problems that we are addressing in this presentation. Supportive housing needs to do more than provide shelter. The traditional housing model often leads to inadequate support for diverse tenants, tenant needs, as it looks at each tenant fitting into a mold. So tenants have complex and overlapping challenges. Some may include trauma, mental health, substance use, and many others. The main takeaway is that these challenges are never the same and can be interchangeable. The needs of tenants are always evolving, meanwhile systems often don't. Every tenant situation is very unique and support will look different for each person. It is important that as staff, we adapt as we need to evolve with the tenant that we serve. There are also organizational and systematic constraints like funding and policy that can hinder effective support. For example, staff can often be stretched thin, and the policy and funding structures don't always allow for flexibility.
So with that being said, we put a question on the board, and we want you to think amongst yourself about what you see as the biggest challenge in making supportive housing truly supportive. When we see this question, our initial thoughts of the biggest challenge in making housing truly supportive is integrating high-quality individualized support services sustainably and consistently over time. It can break down into multiple different parts. It is imperative to provide consistent, person-centered support services. Supportive housing is more than just providing a roof over someone's head. It is about ensuring that the individual can stay housed and build a stable life that works for them. That requires combining housing with mental health supports, healthcare access, employment supports, life skills training, and many other areas of needs. The challenge is making these services tailored to each tenant's needs, having these resources be voluntary but accessible, as well as consistently available despite staff shortages and/or funding gaps. Supportive housing works best when it's housing first with a flexible, dignified support. We need to adapt. So before we go any further, let's dive into our program. So we're with the Homes program at Good Shepherd, and we provide a continuum of transitional and supportive housing and a wraparound services for individuals experiencing chronic homelessness, and with the focus on harm reduction, dignity, and personal agency. Rooted in housing first principles, Homes integrates healthcare, recovery, case management, peer support, and trusteeship models to stabilize housing and improve the quality of life for marginalized adults across Hamilton, Niagara, and we have also some buildings in Toronto. We have 4 on-site buildings, 6 mobile teams who work all over Hamilton, a CHO program, and a transitional housing building. We are grounded in housing first principles, but what really sets us apart is our commitment to evolving with the tenants that we serve. As staff, we're encouraged to think critically, build relationships, and engage in learning every step of the way. So looking at this slide, these are some of the supports that we do offer wraparound. So Jordan and I are the community mental health workers. We work with tenants. We see each of our folks once a week, more if needed, and offer mental health supports, psychosocial supports, as well as helping the tenants navigate the supports that they need to fulfill their goals. We also work alongside peer support workers who also meet with tenants weekly, which provide a safe space for tenants to share their lived experience. We also have community support coaches that provide tenants with life skills. We're fortunate enough to have a nurse practitioner that can go and see folks who may not have a family doctor or may not feel comfortable leaving the building that they're living in, so the nurse practitioner can come to them. We also have consulting psychiatrists in the case of if they don't have access to a psychiatrist with their family health team, we have that option for them. We have a mobile team specified in addiction counseling as well. And for the more recreational side of things, Homes offers every month one social event, as well as events throughout the week as well that tenants can participate in. And we have a Steps to Health program that focuses on health and wellness.
Okay, so person-centered care often gets reduced to a buzzword, but for us it means really listening and adjusting our approach to fit the tenant's goals and what recovery looks like for them. This could mean rethinking policies, changing how we respond to a crisis, and involving the tenant in the planning of their care plan. It is important to note that within the Homes program, we strive to focus on these 5 key points. At the heart of person-centered care is creating a space where the program can honor choice and participation from the tenant, meaning that tenants are always involved in their own care planning and delivery. Central to person-centered care is empowerment. Tenants are supported and encouraged to build confidence and skills to manage their well-being. Empowerment to us means providing accessible information, education, and resources that enable people to make choices, voice their opinions, and advocate for themselves. By focusing on the whole person, not just their diagnosis or symptoms, person-centered care improves quality of life. Personalized care plans reflect the tenant's goals and preferences, which attend to their physical, emotional, and social needs, fostering a sense of purpose and fulfillment. At Homes, enhancing dignity and respect is the cornerstone of this approach. This means preserving privacy, listening attentively, honoring cultural values, and avoiding assumptions or judgments. Finally, for us, person-centered care supports independence by encouraging and enabling tenants to do as much for themselves as possible while providing appropriate assistance when needed. So in practice, person-centered care is dynamic and flexible. It requires ongoing communication, reflection, and partnership. And we will dive deeper into this topic and discuss how the Homes program is able to adapt to serve in person-centered care. So just a quick kind of case scenario on a tenant, and why flexibility matters within the program. So the tenant was initially disengaged from available services and did not recognize the support offered by the Good Shepherd Homes program. Following a self-harm incident, the mobile team collaborated with the tenant and the hospital staff team at the time to develop a comprehensive care and safety plan, with the tenant taking the lead in defining their recovery goals. So since then, the tenant has actively engaged in their wellness journey, including weekly meetings with a peer support worker, which was facilitated with the team initiating that support, regular contact with the team, and participation in Homes program events almost every day. We have noticed this tenant to make it a personal goal to have an event or activity to do every day, which positively impacts their mental health. We also have noted that this tenant has become more open and willing to share with staff when they're feeling unwell or need extra supports.
So a culture of learning isn't just about the individual staff member, it is about the whole system. At Good Shepherd Homes program, we have used multiple different mechanisms that help us grow. We've embedded learning into our processes by having bi-weekly meetings with our managers to go over tenants and self-reflective practices. We are looking at our contacts and reflecting on how we can improve and how we can engage with folks. We're looking at our successes of the weeks, our challenges of the weeks, and what we can always do to improve as a staff member, and also a better support for our tenants. We're also learning from our tenants and peers constantly. We meet with tenants weekly and are learning from them with what works and what helps them the most. We are constantly learning and building rapport and adapting. From a more paperwork side of things, we go over our caseload reports biannually, reviewing care plans, making sure our OCANs are up to date, adding any additional information relevant to the tenant's file, and just making sure we're reviewing, are we giving the best care that we can. We also review tenant records quarterly to reflect that we are up to good practice and where improvements can be made. With that being said, we also have tenant tools. So to foster a culture of learning, we need to include getting feedback from our tenants. We offer our tenants complaint and compliment forms, which they always have access to. They're always in our work cars and on staff. It is helpful to hear that what we're doing well and also where we can improve our service. Through these complaint forms, management investigates and gives a response. If the tenant is not happy with the response, then they can follow up with the director and there will be an investigation and follow-up. Another tool that we use is the OPOC survey, which is the Ontario Perception of Care. This shapes the future of our program. Every year, a tenant will fill this out. Tenants are able to share their opinion through these surveys. We are able to create meaningful goals and create positive change that benefits the tenants in the program. So something that was disbanded due to COVID and we've just reinstated is the Tenant Advocacy Council. So we're in the works of creating a new and improved one. This council will be having meetings quarterly and is co-chaired with our peer support workers. Tenants have another opportunity to share their voice, ideas, and lived experiences. We're very excited to see what the council will do based off their first meeting that happened this month. They already have ideas to be more involved in our Homes newsletter. Overall, a culture of learning is about turning experience into insight and insight into action.
Okay, so the reality of the matter is that systems don't always support change. We have to get creative within the limits of funding and policies. We have to get creative resources and partner with outside agencies to enhance service delivery. Within the mobile team, we are partnering with many outside agencies to ensure our tenants get the care that suits their needs. We advocate where we can and also focus on what is in our control, which is relationships, flexibility, and creative problem solving. Since we are a supportive housing agency, we are committed to the long-term care of our tenants and are always evolving to meet those needs. For example, we have worked with the hospitals to ensure the best care for our tenants, including medical appointments when requested by the tenant. And we work even with the medical appointments, even just being there, just to be a supportive person, not even talking. And we work closely with tenant housing and property managers to provide advocacy when needed. And we also offer various different resources with the Homes program that can be beneficial for tenants based on their needs, some of which we discussed in the Homes overview, like the consulting psychiatrist, for example. Okay, so being frontline workers, we have learned that tenants are our best teachers. They know themselves better than anyone would, and as they grow, we also evolve to support them best. Change must come from both the ground up and the top down. We must learn from both the tenants and management to bring forth quality and sustainable improvements. In using both the tenant tools and the staff mechanisms, we are able to put this into action and truly see how both can benefit the program. Staff need care too. This is an important one. Burnout can be the price of doing this work. As staff, we need to take care of ourselves, as we cannot take care of others when we're not in a good space. For us, as frontline workers on the mobile team, we find it important to rely on our teams and lean on them when we are feeling that burnout. We call it sharing the love. We also find value in bi-weekly check-ins with our management to discuss workload, burnout, and gain feedback when needed. And then evolution is a constant state, not a one-time change. We need to keep growing and changing as tenants grow. Not every tenant fits the same care plan.
So before we close, here are some ideas to take with you. Pick one small thing you can adapt, whether it's a policy, a routine, or a way of responding to a client or a tenant. Find one way to support staff learning and growth. Finally, commit to making feedback from tenants not just something you collect, but something you actually use. So thank you for being here and for the work that you are already doing within agencies and in the community. Change takes time, but it is happening, and we can all learn from each other along the way. If you'd like to connect or learn more about our work in the Homes program, feel free to send us an email. Let's keep the conversation going.
Thank you so much. So just bear with me for 2 seconds as we switch us over. My cursor disappeared. Super. Thank you all. I have a coworker who often tells very bad dad jokes to kill the time while we're doing this. And so I do have one for you. I learned it from him. If you know Quinn Moriki from the prairies and our training team, you may have heard him ask you about a contest that happened years ago while they were developing different kinds of decorative neckwear for people. And they were thinking, what can people wear when they've got a really nice shirt on and they want to add a little pizzazz to it? The contest went on for quite a long time, but ultimately the winner was a tie. You don't have to hear any more of those. I'd like to introduce Dr. Andrew Pizzeri. Dr. Andrew Pizzeri, here you go. Thank you.
Very hard to follow a dad joke and two amazing presentations. Just put my glasses here if that's okay. I'm like a trustworthy person. Yeah, thank you so much for the invitation to be here. Seeing many partners and people in the room, and so really I think to start with, this has really been a collective undertaking when it's come to some of the work that we've been doing at UHN at the hospital with respect to a social medicine approach, or done house, that's been lifted up just over a year ago. But been, almost half a decade of work, and we'll sort of outline and sort of where we are now, sort of a year later, in many of the learnings. Yeah, I don't want to spook anyone or be too spiritual, but I'm very meaningful being back in Montreal. My grandparents lived here, and my parents met here and sought refuge here, and then my grandmother's passed away last year, which was very hard. She shaped a lot of my thinking and relationship with the world. And then I had seen someone who looked just like her when some folks were speaking, and they had left when I was a kid. So obviously her very much with me and really much with this work. So really is a special invitation to be here in Montreal. I think I'm going to hit the key. I don't want to put the AV person on the spot. I got it.
There we go.
There we go.
Okay.
The AV person would have come up and that would have happened. So I'm glad we keep you seated. This to me is one of the most powerful graphs that I've seen on this discussion. And again, being in Montreal, spent a lot of time here as a child. I've seen it more and more in the last few years. The worsening situation right outside where we're meeting, and this is of course not specific to Montreal, but all across the country. And there's a real public debate, if you call it a debate, but there's a lot of polarization that the homelessness crisis is a personal choice, personal failure, or it's about drug use or mental health and addictions, but not really about housing. And I think this graph from CMHC really obliterates that notion. So if you look at where we were in 1972, 1974, we had about 1 in 5, about 20% of all housing supply was affordable or social housing. That has atrophied dramatically with chronic policy choices. So again, the reiteration that these are policy choices that are driving our communities and people and patients into homelessness. And it was encouraging to hear the Minister of Housing this morning. So they were looking to double the rate or triple the rate of social housing in the country. But as a reminder, even if we double the amount of social housing in Canada, we would be just under the OECD average. So we have a lot of work ahead. And again, I think where there's such a collective push in this room and at the conference and across the country. So what does that mean at the hospital level? And again, I speak from my vantage point as a primary care physician and someone who works with people predominantly who are unhoused, especially at inner city health associates. It means that people who are chronically unhoused live 30 to 40 years less, maybe 20 to 30 years for more recent data, but really across all jurisdictions, this really holds true. And I find myself, talking with colleagues like Dr. Mike Anderson who are here, where we lament around the fact that if there was a drug that could restore 10 years, 20 years of life expectancy, you would think every funder would be tripping over themselves to bring that to market, if you will. And the reality is we know what that treatment is. It's housing, and housing for all. And again, these are real policy failures and lack of action that come with very detrimental health impacts that many, all of you, are aware of. But this is what we end up seeing in the emergency department. So when we looked at the data at the University Health Network, when I started around 6 years ago, there was this view that University Health Network, a global institution doing terrific work in transplant to cancer care, didn't really have a community or wasn't a safety net hospital. The reality was, with the data, that was fundamentally untrue. We had 100 UHN patients make up over 4,300 ED visits in 1 year, and when you actually expand that, 234 patients made up over 15,000 emergency department visits in the downtown core. And I do know from lots of this work, and many of you leading this work across various cities and towns, that pattern holds true. And we've known this for a long time. I think folks may remember Malcolm Gladwell, who at times says he's Canadian, at times says he's not Canadian, but did write for the New Yorker about $1 Million Murray. And I think there was this view about 20, 25 years ago that it's a real societal cost, economic cost to the fact that people are unhoused. But I think really where we are and rooted in housing, there's a real human dignity element. So some of the latest research on the health and housing piece that wanting to share that, again, when we are failing people with out housing, they end up staying twice as long in the hospital. This is from Kai. Terrific researcher Lucy Richard at Unity Health had a more recent paper showing that the cost for people who are unhoused is about 7 to 8-fold higher than people who are housed. And again, this means that there are worse chronic disease conditions, mental health conditions, and all of this even exacerbating cancer risk by 2 to 3-fold. So I think that the data is really clear on the homelessness crisis being a health crisis. And again, I think where can we look at some of the interventions to try to interrupt this cycle upstream, if you will, not being outside of the emergency department or primary care clinic where many of us work. So the economic argument, and again, this is a very conservative basis in terms of some of the rationale for why hospitals and hospital networks should be encouraged. Again, if the health and human dignity and health cost to people's life expectancy isn't compelling enough. The reality is that this is $32,000 for a month in the hospital. It's probably closer to $50,000 or $60,000 for a month in hospital, depending where you work. And again, the provincial jail system, looking at around $15,000 per month. And a dear colleague of mine, Lana Fredo, calls it the de facto mental health system for people in the prison system. And I know there's been many great talks here this week around this connection between the justice system, the housing system, and homelessness. I can recount many patients who tell me, especially in coming to the winter months, that they thrown a stone through a store window in hopes of being arrested to get warmth, to get care, to get support, and to get help. Again, I think this underscores the real failure of our social systems and our health systems in responding to the needs that people have. And then again, around $3,500 to $4,000, $4,500 is still a fraction of what it looked like for supportive housing. And obviously, there have been some really great models presented here earlier today. So a little bit around the social medicine work that I get to lead at UHN, and look forward to staying in this role. God willing, don't have any political ambition on this piece, so really do look forward to this work and seeing Lori Steer and some other partners that we got to chat about where we want to go for the next 5 years. And I think it was great to hear the minister talk about prevention. We want to do more of that, and things where we can keep people out of homelessness, housing stability, and again, really talking about this integrated health and social care model. And I hope this is one of the takeaway themes when it comes to Dunn House, the importance of integrating healthcare and social care in ways that there have been models across the country, and we'll really hope we can take a bit of a deep dive on the one that we've been leading in Toronto for some time. The one part I just have to say, because I think the public and folks will look at the costing and emergency department visits and hospital admissions, and obviously that's a very important factor if you're convincing hospital COs or hospital boards as to why they need to be integrating their lane, not stepping outside of their lane, but thinking more broadly about health. That's really important. But I always would be remiss not to say that I've never had a patient in the shelter system or at Inner City Health who has ever told me, Doc, my goal this year is to go from 10 emergency department visits to 4. That's never been a performance indicator for them. And I think really this hope in this discussion is how do we align better care with hospitalization metrics, with system metrics, but really about the patient-reported outcomes and experiences. And people being able to determine health and well-being as they choose. And I know this is a very hot time and a hot debate as it comes to challenges around safe consumption of drugs, harm reduction in the country. I think many of us wouldn't have imagined we'd be here in 2025, given all the advocacy 10, 15 years ago for a very long time, and we're seeing some really harrowing closures of safe consumption sites in Toronto and elsewhere. So really, I think the idea that this fight continues, and I think continue to ensure that the way people choose and define their health, not just as hospital administrators or as physicians or the healthcare system, deems it to be, has to be really central in the way we define success. And a real big part of that, and I know it's been focus at CAEH, is the importance of lived experience and lived expertise. I'll talk a lot about around some of the data, some of the stories, and I think really one of my takeaways is that for policy change, I think one of the most powerful combinations you can see is data and lived experience coming together to shape and share and inform hopeful policy change and reform that many of us are committed to. And so a real special thanks to Opal, Michael, and Renee, who were sort of the original members of our Lived Experience Advisory Council. It has now expanded to 10 members, but I can tell you with certainty that Opal, Michael, and Renee do have my cell phone number and will tell me every other day about what we're doing well, where we need to continue to move and push. And I'm really thankful for that accountability and that ability to work alongside many individuals with lived experience. So a little bit of background in terms of coming towards Dunn House. And I see, Victor Willis here, who's done some really great work and leadership in Parkdale. That's where the Dunn House project is, for those of you who aren't familiar with the Parkdale neighborhood. A very progressive neighborhood, I think a really special community of people looking out for each other. There's a large immigrant community and refugee community as well. But not immune from a lot of the gentrification that's happening and has happened in the last 10 years across the country. And what were we going to do about NIMBYism? And that it was not something that wasn't evident or present in Parkdale. So I don't want to give the picture that these kind of projects can only happen in neighborhoods like Parkdale. The hope is obviously that we can scale, but what do we do around these public perceptions of safety, of what does welcoming look like? And really grateful to the United Way and West Neighborhood House leading a lot of community engagement sessions to give people information about what was coming and really trying to take this head on as opposed to trying to respond and react to, I think all of you have seen some really well-resourced mobilization, whether it's about safe consumption sites or new housing in neighborhoods. They've been very well organized. And I think there was really this belief that we need to come with the same organization, the same community outreach, even beyond. And so this is a sense of some of the work that went underway to start to prepare the groundwork for Dunn House and the idea that 51 new neighbors would be coming into Parkdale who've had long experiences with homelessness and a lot of challenges. And one of my favorite things about the welcoming is that people actually prepared tote bags and care packages for everyone who was moving in. And really this sense of embrace at community town halls and various meetings around why Spunta, which is one of the tenant associations in the neighborhood with UHN, was one of the most vocal proponents and supporters for more neighbors on their block. And so I think a lot of credit to the Parkdale community needs to be acknowledged. So this is what Dunn House ended up looking like, the front side of the building. This was, again, work that was set out in 2020 through an MOU with the City of Toronto, the United Way, University Health Network. And again, talking about healthcare overreach or hospital overreach, you would never want the hospital to be your landlord, quote unquote. And this was really where Fred Victor is a pivotal partner. I know Keith can't be here today, but working with Fred Victor with long experience in supportive housing as the nonprofit operator with the 24/7 supports that are available at Dunn House. And again, a long list of partners. And really what we were able to do was take a parking lot in Parkdale that was owned by UHN. I think there's no one from my chief legal team at UHN, is there? I can't say donate. So we leased the parking lot to the city for $1 It was essentially a donation of land, but legally we're not allowed to say that. So if you live tweet this, I will be in trouble, but we will be clear that there was a transfer of property for $1 to the City of Toronto, which was able to build into the Rapid Housing Initiative with the feds to get the capital investment, and then the operating from both the province and the city. And so we'll get into some of the details of how that can work. This is more of the photos of Dunn House. The interior, again, really with a bed and bathroom. There are 15 barrier-free units in the 4 stories and 51 units. Some of the unique aspects, there's a clinic space that's built right in, and really fortunate that Intercity Health Associates has supported this work, which we'll get into some of the clinical components, but there is a clinic space that is built in on the first floor where people have full access, as well as a common area. And one of the things that we heard very directly from patient partners was the need for pet-friendly policies, so that's something as well that was there. I mean, I see a lot of shaking heads. I mean, it's great, but it has honestly made me 10 minutes late for clinic every Monday. I'm saying that in front of my medical director because there's a puppy named Max who's moved into Dunn House, and you are cold-hearted if you try to step over this adorable thing to clinic, who has totally posted up outside the front door at Dunn House and has been a fixture there for the last 3 to 6 months. When we look at the model, again, some terrific presentations earlier, trying to layer in the health and social care components. So one thing I think to be clear about is that the idea of prescribing housing, which I know has received this idea of novelty in terms of where it's UHN patients we've talked about have some of the highest healthcare needs. They've been waiting the longest on city by name lists to be able to get in. Yes, in theory, we sign or write a prescription for housing for patients at UHN, but really I have to underscore that it's the community health workers, the peer support workers with the neighborhood group, folks who are working in case support who spend months working with clients and patients to help them trust us as a healthcare system, which they rightfully should not and have not. And to build that, to be able to say they believe this is going to be here and what supports are going to be there when they actually get in. And the Fred Victor team, again, doing really tremendous work on 24/7 support. And here you see that there is peer support work, personal support workers, CHWs and social medicine navigators. There's a nurse practitioner on site, myself as a general practitioner. We have psychiatry. And we've tried to bring in more UHN resources by the way of a general internal medicine outpatient clinic. And Intercity Health has been instrumental in having psychiatry access weekly, which we'll get to a little bit of the baseline, and mental health and addictions treatment, again, which is there. But it is also, to be clear, this is a harm reduction positive site, that this is not an abstinence-based model. And the other piece that I think is important to note is that people hold a lease like you or me. This is not a 90-day or 120-day or transitional housing. There's, of course, real important needs for that in the country. But given the realities in Toronto, where we have 300 calls every night unanswered for the shelter system, we really wanted to work with the city to ensure this was a housing exercise or housing for all and not a hospital discharge exercise. So there's this permanent supportive housing. And again, we have much to learn in terms of a lot of the different models and feedback loops that were presented earlier today, but we do have some advocacy councils, the Lived Experience Advisory Council informing what's been in place, and the Indigenous Health Program from UHN has been a central part of trying to co-design what kind of programming can be there for all tenants, but especially a focus for Indigenous patients and clients who are living there. So we have surpassed the target of over 25%, or 1 in 4 Indigenous tenants at Dunn House. The range is actually, to me, one of the most beautiful things about Dunn House is you have people who are in their 20s to patients and clients in their 70s. And, you know, I always ask one of our clients there who's in their 70s, you know, some people ask, what are you doing here? And they love it. And there's actually the relationship with the oldest patient with the youngest client or tenant in place, and how he looks out for her and makes sure things from groceries to ensuring that no one's causing them any trouble. it's really an amazing community that's forming, and how people really look out for each other across a range of diversity and across a range of age diversity as well. And so we have 15 barrier-free units I mentioned for people with physical disabilities and wheelchair access as well on site at Dunn House. So some baseline characteristics, again, I think these are underreported, I'd have to say, but we've been able to work with partners at U of T and Boston around some of the research to be in place. And so here looking at high degrees of violence, none of this I think surprising or shocking to anyone in the room. More than half of days feeling complete limitations or limitations with health status. And I have to really say that the people that are and have moved in to Dunn House are very sick. You know, they have had years and decades of marginalization. There are real serious physical health and mental health conditions. A number of patients are palliative, and the Intercity Health Associates team with the Peach team and other palliative supports there. And we'll get to some more of the costing, but I always question, how can you capture the economic value or cost of someone being able to pass away in their own home as opposed to the street or encampment? And that's something where we draw encouragement that there are palliative patients who will finally get access to Dunn House, and hopefully much more. And again, I think real limitations, which is well known in the sector of trying to access primary care or mental health specialist care. So this is a story to go into the individual level of Jason Miles. If people haven't read it, I think there was a really terrific story done by Victoria Gibson that profiled Jason. I really commend him for his courage to be so open about his journey, his story. And really, I think when the Toronto Star with Jason tallied up what his journey looked like, again, very reminiscent of, you know, $1 Million Murray, and now we're seeing, of course, more with the refugee newcomer challenges in the housing space and homelessness, you know, $1 Million Mohammeds and Marys and Jasons that are not exclusive to Dunn House. But again, I think this reality that our failure to house people has real health ramifications, but also pressures across the system, not just the emergency department or hospital inpatient stays. And so here, some of the quotes, again, that have been coming through from Jason, not only in the story, but some of our work. Again, I think the reality that people can store their medicine safely for the first time, be able to feel that they can access care, the food security pieces. And here, a photo with Fred Victor and the tenants, Jason there above, and again, really the team with community health workers and caseworkers that are constantly trying to evolve as how we can make this a more accommodating experience, but one, again, that aligns on this sort of integration between health and social care teams. So the UHN team working hand in hand with the Fred Victor team, and again, community partners like the neighborhood group, Intercity Health, and many others. Parkdale Queen West Community Health Center, again, deserves a lot of credit for the work in the neighborhood for many years, and the need for housing and some of the supports that people are receiving. I'll leave space on one quote here from Matthew, who again has been open around his challenges with chronic disease management and challenges of being able to control his diabetes while living in encampments and some of the real benefits. And so again, we're happy to share some of those stories that have been made available publicly online. But again, I think Victoria and Liam Casey have been able to capture some of these portraits and stories for people that I think are best positioned and most powerful to hear directly from them. So some of the early results that we just reported a few weeks ago now, so I think a timely day here in Montreal, we did see a 79% drop in hospital bed days for people from the pre-period to the post-period. Dr. Mike Anderson and many others are involved in a more comprehensive study that will hopefully be out later this year or next year, but also seeing a drop here from the hospital data alone in emergency department visits. We're able to be cut in half. And again, when you look at the fact that at the hospital level, emergency department visits cost around $462 to an in-bed stay is about $2,400.62. We have roughly $2 million in averted hospital spend. And again, I think this number is actually larger when you look at many of the other intersecting sectors that folks end up having to resort and rely on for many of you as the last thread of the social safety net. And so I think that brings us right to time. So thank you very much. And to leave on that, I know we have a really full Q&A session. Thank you.
Thank you so much to Dr. Pizzeri and to all of our presenters here. I find this is one particularly interesting, hearing so many conversations about upcoming budgets, about pending austerity, and the way that our work does cost quite a lot, but that the net cost to not doing our work outweighs it tenfold. And so being able to quantify those impacts, being able to describe it in a way that matters. We've all been saying that housing is cheaper than shelter, and shelter is cheaper than jail or hospitals for years. But to actually map that out and to show examples of what it looks like when we act on that is a wonderful tool going forward. So thanks once again. We have about 20 minutes left for questions from the audience. I do have a wireless mic, and I will step down and carry it through. But I would ask you to raise your hands. Et puis, s'il y a des francophones dans la salle, il serait mon plaisir de traduire pour vous, si vous voulez. So if anyone has a question, please put your hand up, and I will come down and meet you with a wireless mic shortly.
I suppose I could have walked up there. Yeah. Thank you to all of you for those presentations. I mean, it's as thought-provoking as it is inspiring and motivating to hear about the work that you're doing. So thank you very much. My question actually is for, I'm probably not allowed to ask each of the 10 questions I have for all of them. No? Okay. So I'll ask a question of Alyssa and Jordan. Part of my responsibilities in the work I do, just kind of down the road from you guys, is to try to take care of the folks that are doing the work. So I'm really glad to see that you had that in your presentation as a priority in recognizing that people on the front lines doing this work are in impossible situations right now. So I wonder if you might be so bold as to tell us a few of the things that you would like to see in the work that you do from your management and your leadership to keep you doing the work in a safe, secure, and happy way for as long as you want to do it. I'm quite interested in that perspective from your lens. Thank you.
Definitely. You're definitely putting us on the spot because our director is sitting right here. Yeah, you go. Oh,
They won't.
I don't know. Yeah, I think just like for us especially, being on a team and being able to like really lean into each other and like I kind of mentioned, like really share the love. And I think it's, yeah.
I think it's important, like, especially with, like, the management team, that there is, like, this open door policy as well, where, like, when we're struggling with this situation, we can go to our management and, like, say, let's talk about this. Can you guide us? Or, like, just debrief, vent, whatnot. Having that open communication with leadership is, like, super important. Yeah.
Thank you.
Thank you. Hi, my question is for Dr. Pizzeri. First a comment and then a question, if that's okay. My name is Dylan. I used to work in human shelters for about 15 years, and I now transferred to animal shelters. So I'm a veterinary social worker, so to hear the story of Max was fabulous. So appreciate that Dunhouse is pet welcoming. On a side note, if there's anything we can do to help support the animals, happy to do so for anybody in the room as well with your shelters. But my question, I suppose, is it sounds like a really, in some ways, obvious model. And I guess I'm just sort of wondering, is there going to be a publication attached to this model so that, or a blueprint so that it can be, you know, replicated in other spaces, in other communities?
Yeah, thank you so much, and we will definitely take you up on that offer. It's not just Max at Dunhouse, so thank you for that. Yeah, so hopefully soon, and I think we're looking at some of this with some of the different municipalities through AMO and others that we've had conversations with to see where the best venue would be for, you know, publishing the playbook, as you put it, in terms of, you know, leveraging public land, trying to figure out again around, you know, again, very obvious needs for integration between health and social care. I think the real challenge has been, I think, chronically, that there's not integrated budgets to be able to do this work. So I think when you look at this, it seems, again, so straightforward. This is how it should be, but we've not actually seen integrated budgets. We've not seen that sort of deliberate focus on operational dollars, as well as some of the capital, which you've talked about, not going towards social housing or supportive housing. So we're looking at what's the best way that would be most accessible beyond some of the academic publications I alluded to. And again, I think the academic work is incredibly important. I think the challenge is, you know, there's a real lag, and it can be many years later, given how rigorous and comprehensive some of the evaluations are. So TBD, or coming soon, and happy to stay in touch in terms of where and when we can get it out in sort of the most accessible platform or venue.
Great. I do think my one major criticism of this presentation was that we didn't get to see Max. So I do hope to see that in any future work that you do as well.
Hi, thank you. I'm from the City of Greater Sudbury in Northern Ontario. We just opened a transitional home. I'm from Health Sciences North, and we worked really closely with the City of Sudbury. I don't know if any of there's my colleagues from the city. So my question actually is for Good Shepherd. You talked a little bit about sometimes working with some of the challenging clients, and I'm just curious about how you might manage some of those really challenging clients with respect to behaviors, and do you have protocols? I appreciate that it might be an in-depth strategy, but just wondering if you have any thoughts on that.
For sure. So with us, like we said, we share the load. So we work on a team of 5. So we'll always take turns going to see the client. And with like behaviors or challenging things, we'll double staff us when we go on visits, just to ensure like safety for everyone. And then we, like, without getting into like client situations, we do like get creative on how we handle things. So it's a lot of like game planning, prepping before we go into the visit, I feel, of preparing how the visit will go.
Over communicating too with the team, kind of having that open line of communication, bouncing off of our managers and directors if we need to. And yeah, just kind of collectively working together, and definitely the double staffing works. And the good thing with having a bigger team, just from us working in mobile, is that with challenging people, you can take breaks. So we see people every week, but with having 3 people on the team, you can kind of switch off so that if you kind of need that break, or you can't necessarily like deal with the challenge, then it's good to kind of be able to get that opportunity to take that break
And trade it off.
Yeah, and trade it off and all that.
Thank you.
Thank you, everyone. This is a question for everyone, actually, is your thoughts on ways to prevent the cycling of people who've made it into supportive housing back into homelessness, and sort of what your efforts are and what you're seeing.
So this was something that definitely occurred to us when we were designing this project, because it was a question not only of like the longevity of a person staying in supportive housing, but like how well they're doing. And in terms of cycling back into emergency housing, a lot of it was figuring out that we had to lean into like the devil's in the details, and lean into that when it came to adapting people's supportive housing, not only in their accompaniment, but in the environment. and one big takeaway from this project is that people feel that their agency is compromised. They still feel like they're in an institutional setting. They still feel infantilized. And if you don't feel empowered, if you don't feel like even the environment is strength space for you, that definitely lends itself to putting you at more, like a higher vulnerability of potentially entering back into the emergency system, right? Because it's not working for you. So I think all of us are trying for that, is to make the housing work for people and not just in the sense of a place to put them.
I think for us also, like when tenants come into our program, they are signing a program agreement. They're agreeing to meet with us, have us really heavily involved into their lives, and we try and find ways to help them stay housed. So whether that's working with a cleaning coach to keep their unit up to housing standards, or us going in and doing that as well, getting them the financial supports if they need it, like navigating that with them. We're working at all the areas just to maintain their housing. We have a building in our program that does like have people who are hard to house in it, and we're doing everything we can to keep them there by adding those extra supports.
Yeah, like I think it's a great question, and I think these efforts are really valiant. I mean, the reality are that it is really challenging. It's for some folks, and obviously to want to hear also be supportive of the safety of the staff and people who are there as well. If you have some people who've got some behavioral disorder or other challenges in terms of violence or histories of violence, so I think there's a lot of efforts to prevent evictions. We've seen some success, a lot of success in that. I think the other part you and I have talked about is how can we ensure more programming around some of the boredom and issues that can come up as well, and how to continue to bake that in. It's not going to be for everyone, but I think for some of the individuals that have higher risks of that kind of those outcomes, it might be really helpful as well. But this is an area where I think we're constantly looking at the literature, and I think it's evolving, especially around various substance use behaviors and how there are ways to have supports, as this is a very different field than it was 10 years ago when it comes to management of opioid use disorders, and that now being something that has a lot more complexity when it comes to some of the treatment options.
There we go. I have a question over here, and then I'll be over there.
Thank you. Actually, hi Hannah. I just wanted to add something to her answer, as we work in the same organization. I think at the Oldbury mission, a chance that we have as well is that we have quite a couple of different supportive housing formats, in the sense that sometimes we integrate someone into some kind of supportive housing, and it ends up not being a good fit. But we have transitional housing, we have permanent housing, we have pavilions, we have in the community apartments, we have rooming houses. So as much as possible before someone goes back into the streets, we try and transfer them into another one of our services in order to try and adapt our services to the person and not ask the person to adapt themselves to our services, kind of thing, I think.
Yeah, thank you so much for that. It's a great point, and I think it's sometimes a hard pill to swallow, but an important feature, that a continuum of care and a continuum of housing is not linear. It's a spectrum, right? And it's not a failure to change to a different housing model. Thanks so much.
Hi, Victor Willis from the Toronto Supportive Housing Network. And what's great about the question that was asked and the answer, it's kind of like Andrew's comment on integrated budgets, is that we actually need an integration of the kinds of opportunities for individuals based on their ability or what they need in order to be able to be successful. So much of our goal here is to get people off the streets, because it's a catastrophe, and so we acknowledge that. But the other part of that is that people have different needs, and being able to actually address. I mean, I'm wondering about. So from the panel, the thing that we often look for are, how do we start to focus in on being able to, when I think of treatment, or assess, how do we in fact do better at assessing, so that we can start to tailor that this individual needs this kind of program, but they also have the ability to recover. And we see that in supportive housing, that people recover, they regain the ability to live with others. Some of the things that they, that are part of their addiction, if they can shed those things, they're able to then become much better neighbors. And it's, of course, that's the quality of that we're looking for. We really want people to recover. So to not be pejorative about how they've been able, the trauma and how they've been able to survive on the street, but what's that pathway to becoming more capable members of society without any kind of judgment? So I'd love to get a sense from the panel about that piece, and especially emerging practices from better referral and assessment. Thanks.
I don't necessarily have a punchy reflection on referral and assessment in the initial, like when somebody's initially brought into supportive housing. I think like good continuum of care practices generally apply to that. I think too, like if I'm speaking on behalf of the participants, so the people who are actually accessing the resources, they might say that it's like a continuity of care plan. It was often reflected that the way staff changed, there could be a care plan in place, but when staff left, it never was the same. And I think if there is an assessment, if there isn't a referral, it's having a continuity to that care plan that reflects that person and not the staff member. And that's so challenging, and in real time, I don't know what that looks like, but I think that's part of it is that getting it right the first time and then following it through regardless of who's doing it.
Do you want to go ahead?
Sure. For us in the intake, we go through the intake form with the tenant. They have the opportunity to tell us, like, what does you being unwell look like and how can we best support you, giving that options that we know how to support them the best. And then it also outlines what they need support in. Like, we ask them, do you need support here, here, and here? And then we grow from there, building those relationships. And maybe along the way, maybe they didn't think at the intake that they needed support. And as we grow and build rapport with the tenant, then we figure out the other areas where they learn they need support in as well.
Yeah, thanks, Victor. I mean, I would answer it as well from the health care component. I think one of the things that was relatively unique around Dunhouse is that there was a major component around the health needs that were coming to Dunhouse. And then I think, as I mentioned, a real panoply of services from psychiatry to mental health to general internal medicine, for issues around, cellulitis to other chronic diseases. So I think doing that in the referral and intake in a coordinated way between, health providers as well as, frontline caseworkers and support workers, I think has, huge merit. I do think this is an area where we probably need to see this, I think what you're alluding to is sort of precision supportive housing. What does that look like? And I think the data is going to be really important, but I really want to underscore the points that were made. I think the relationships are really foundational, and I think there'll be some folks, I've been really fortunate to work well with in Dunhouse, but others who have a relationship with a nurse practitioner who's phenomenal. And, and I think and the same with various, CHWs or folks who are on the team. So how we can build towards the relationships while leveraging the data to ensure that the right sort of mix of supports are there. I think that's actually, to me, a really exciting element of where hopefully supportive housing can move.
Thank you so much. Oh, thank you so much. I'm back on the air again. Yesterday, I had the really incredible pleasure of talking to somebody who described their role in partnership development as holding the storyline, which stuck with me quite a bit. And later on, heard somebody talk a little bit about continuum of care in somebody's life being a part of the continuum of their life, that their life is a storyline that travels even beyond the continuum of care that they receive. And there was something really interesting in putting those two ideas together, and thank you all for adding to that as I build out that story in my head of how we move into lifelong relational deep care and moving people towards the life that they will be stepping into when they access services in a good way. We are now at time. It is noon. I would urge all of you to stick around if possible for the 12:30 keynote from Jesse Thistle. That will be our closing keynote for the day. It is going to be incredible. Between now and then, Some of our presenters may have time to stick around for questions, but I will not put them on the spot to do so. But you are welcome to talk, dig in deeper, and we will have those slides available for all of you afterwards as well. Thank you so much for joining us.